Hello, and welcome to this VJHemOnc podcast, where we'll be sharing the latest updates in Hodgkin lymphoma. This podcast is part of the Lymphoma channel on VJHemOnc, which is supported with funding from AstraZeneca, Bristol Myers Squibb, Johnson & Johnson, Takeda, and Galapagos. These supporters have no influence over the production of the content. Hodgkin lymphoma is highly curable for many patients, but important questions remain around how best to select frontline therapy, reduce long-term treatment toxicity, personalised treatment intensity, and improve outcomes after relapse. In this episode, we'll hear from experts discussing recent clinical trial data, evolving frontline strategies, the growing role of circulating tumour DNA, and emerging approaches in relapse and refractory disease. This podcast is intended for healthcare professionals only. Let's get started. We begin with recent data in frontline classical Hodgkin lymphoma. Graham Collins presents the final 3-year results from the AVENUE study, which evaluated the PD-L1 inhibitor, avelumab, before response-adapted chemotherapy.
So the AVENUE study was an investigator-initiated study. It was looking at using avelumab, which is a PD-L1 inhibitor, in the first-line treatment of classical Hodgkin lymphoma. We gave it before then embarking on the RATTLE approach, which is 2 ABVDs, PET scan, 4 AVDs if you're PET negative, escalated BCOP if you're positive. Now, we've already presented the overall response rate. That was 45%. Now, that made it a positive study, but perhaps it was a little bit lower than we sort of had hoped, and it was only an 11% CMR rate. However, the progression-free survival was excellent. So the 3-year PFS is 91%. So very few people relapsed, and 100% overall survival. So, great data. It's not going to be taken forward, avelumab, in classical Hodgkin lymphoma. There are other PD-1 interrupting drugs that have now got an established role, such as nivolumab. But it was certainly a very interesting trial to do. We had some patients who experienced immune-related adverse events, which we will see with nivolumab AVD, if and when we'll be able to use that as a standard of care in the front line. And it was certainly very gratifying to see such a high cure rate with that trial.
As new approaches emerge, attention is increasingly turning to how best to select between highly effective frontline regimens. One of the key debates in advanced stage classical Hodgkin lymphoma is the choice between BrECADD and Nivo-AVD. Graham Collins explains why BrECADD may offer advantages for selected younger patients, including a shorter treatment duration.
So in classical Hodgkin lymphoma, one of the big points of controversy now is if you had everything available, and not every region does, and certainly in England we don't, but if we had every sort of regimen available, which one would you use in advanced stage patients? And the big two are BrECADD, so that's an evolution of escalated BCOP to involve rentuximab, switching procarbs into dacarbazine, prednisolone to dexamethasone, fiddling a little bit with the other chemotherapy doses. That's BrECADD. And that's quite an intensive approach versus nivolumab AVD. So it takes ABVD and simply replaces the bleomycin with nivolumab. That's the SWOG 1826 study that showed a benefit over BVAVD for that regimen. Both are excellent regimens, there's no doubt about it. But the debate we were having is, particularly a young patient, would you use BrECADD or Nivo-AVD? I was arguing for BrECADD. I do believe quite passionately in BrECADD there, partly because the 5-year progression-free survival in the 18 to 60-year-olds from the HD21 study is 94%. I mean, you can't get much higher than that. 94%, excellent. Nivo-AVD, a little bit lower at the 3-year mark. That's 91%. Of course, the trials aren't identical, but still an excellent result. But the real advantage, I think, of BrECADD is the duration of treatment. So for most patients, they only need 4 cycles, and that's over in 3 months. So I was trying to illustrate that, it's June now. So if we started a young patient, we'd be finished by August and they may be able to go off to university because they're often young patients end of September. Whereas if they were on Nivo-AVD, that's always 6 months of treatment and we'd probably be just about ruining their Christmas, because it's so much longer. So that short duration of treatment enables people to get back to work, back to their studies much more quickly. So I think for the right patient, not for every patient, but that more intensive, shorter approach with excellent outcome data is the right way to go.
Stefan Ansell offers another perspective, highlighting how age and fitness may influence treatment selection, particularly for older or frailer patients.
So I think what's interesting is nivolumab AVD chemotherapy is a standard and BrECADD is now a standard. So both of those, I think, are very effective therapies, and a real debate has developed in the field about which is your best choice. Both of them give excellent results. I would say that elderly patients seem to benefit a lot from nivolumab-AVD, and certainly in the US, that is a standard for older patients. However, at this EHA meeting, there's some updated data for BrECADD in older patients also showing that that's very well tolerated. So I think the debate continues. In our practice, we would specifically consider nivolumab-AVD, particularly for older patients. Especially a frail patient, you can often just give nivolumab first, get the patient to have a degree of response. That makes them actually be more able to tolerate the AVD part of the chemotherapy, and that allows us then to give a kind of more effective therapy with good results long term. I think the one thing that we had hoped but hasn't turned out is that maybe you could just use new drugs, nivolumab and brentuximab vedotin, just together and skip the chemotherapy entirely. The problem is, unfortunately, while the response rates are good, the durability has been disappointing. So I would say that's probably not your best strategy.
With multiple frontline approaches delivering strong outcomes, the question is increasingly not only which regimen to choose, but whether treatment intensity can be adapted more precisely to individual patient risk and response. In Hodgkin lymphoma, maintaining high cure rates while reducing unnecessary treatment exposure remains a major goal. Professor Collins discusses the long-term toxicities associated with current therapies and considers how cell-free DNA analysis could help identify patients suitable for treatment de-escalation.
So some people would say that Hodgkin lymphoma we're done with now. The cure rates are so good. What's there to research? But actually, there's a lot more we need to do. So the treatments we give, whether it's intensive, such as BrECADD or escalated BChir, whether it's a bit less intensive, such as Nivo-AVD or BVAVD, this is still chemotherapy. If we use an ABVD backbone, we're giving patients 300 milligrams per meter squared of doxorubicin. That has a significant risk for their heart later in life. And in young women, it increases their risk of breast cancer. So we really shouldn't sit on our laurels and think we've done everything. We need to be thinking who is doing really well, and therefore who can we dose de-escalate. We know from a study from South America that even in advanced stage disease, you just give 3 cycles of ABVD and many patients are cured. So who are those patients that can be cured with much less chemo? And really the way forward here, I think, is doing cell-free DNA analysis. So we've already seen that this has real potential to identify low-risk patients. So we know that already. But what we need to be doing now is to doing preferably randomized trials where we can integrate that and showing that identifying low-risk patients, randomizing them to standard treatment and less intensive treatment maintains that very high cure rate, but also reduces both short and long-term toxicities. So there's still a long way to go. And ultimately, why are we giving patients chemotherapy at all? There are many other lymphoma subtypes where we've gone chemo-free, and ultimately that should be our aim. So there's still a lot to do in the field.
Building on this, Sven Borchmann discusses the prognostic value of circulating tumor DNA-based measurable residual disease assessment, including at early time points during treatment.
Yeah, so having just talked about using ctDNA for classification, I think the story is different for using ctDNA for MRD, minimal residual disease detection. So here, now really multiple studies have shown that ctDNA MRD in Hodgkin lymphoma is highly prognostic. And it works, and that's a bit different to other lymphomas, also at a very early time point. So it's been shown that even if you look after 2 cycles of treatment out of maybe 6 cycles of chemotherapy treatment planned, you have a prognostic effect that's very strong. So you can use this now, of course, to escalate or de-escalate treatment strategies based on this very patient individual risk assessment. And here the tools are increasingly available. So there's multiple assays available that you can use. And I think here, from a practitioner's perspective, one should really think in cases where maybe PET readout is challenging or where you have other reasons to really individualize approach to start using these tools and measure MRD in Hodgkin.
While efforts in the frontline setting focus increasingly on treatment optimization and de-escalation, major challenges remain for patients whose disease relapses after checkpoint inhibition. Guilherme Perini discusses the Phase II KEYFORM-008 trial, which investigated whether dual LAG-3 and PD-1 blockade could restore sensitivity to immunotherapy in relapsed or refractory classical Hodgkin lymphoma.
The KEYFORM-008 was one trial looking at what we call the post-PD-1 scenario. We know that these patients with Hodgkin's lymphoma that were treated with a checkpoint inhibitors such as pembrolizumab or nivolumab, especially in monotherapy in the relapsed refractory setting, they will eventually progress on the therapy. And we don't know yet how to treat these patients. So the idea was to test a combination of pembrolizumab with favicizumab, that's an anti-LAG-3 checkpoint inhibitor, in these patients as a way to regain sensitivity to PD-1 blockade. And it was a randomized trial against the investigator choice of chemotherapy. So the study was positive. The PFS was better with pembro-favi than with chemotherapy. The disease control rate was pretty similar, although we did see more complete responses in the chemotherapy arm. But these responses are very short-lived. As soon as the patient stops chemotherapy, the patient relapses again. So it's a proof of concept. We now know that we might regain sensitivity to PD-1 blockade, but unfortunately, to a business decision from the sponsor, the FAVI program was discontinued. So it's a proof of concept, but I don't see this becoming part of a reality right now. The results are good. There's a proof of concept that these new checkpoint inhibitors work. They are able to regain the sensitivity to PD-1, but I still think that this scenario of the post-PD-1 in Hodgkin's lymphoma remains very, very challenging. Of course, when we're using it in first-line therapy, the number of patients that will eventually fail therapy becomes lower and lower. We're curing way more patients that we used to cure with chemotherapy alone or even with ADC combinations. But I think that these patients is still standard treatment for these patients. What we usually do for these patients today, I mean, we may try chemotherapy, we may try allogeneic transplant, but I really think that biologically, trying to regain PD-1 sensitivity is really, really important.
The growing use of checkpoint inhibitors and brentuximab vedotin also raises practical questions around treatment sequencing. Cathy Burton discusses how access to these agents is shaping the management of relapsed Hodgkin lymphoma in the UK.
So this is a real challenge in the UK because really our availability of being able to use BV and PD-1 inhibitors is fairly limited. So at the moment, we don't have any access to PD-1 inhibitors first line other than through clinical trials. The ratified trial does use tislelizumab, so B1's PD-1 inhibitor up front. But as I say, that's just for a small number of patients over the age of 60. So at the moment, we can use BV-AVD for stage 3 and 4 advanced Hodgkin's lymphoma. There is also the RADAR trial looking at using BV-AVD in early stage disease. But otherwise, we're really using these agents beyond first line. Interestingly, we don't actually have access to BV or PD-L1 inhibitors or PD-1 inhibitors second line. So we only have those available as monotherapy third line. So traditionally, really, we've used a chemotherapy approach and then a transplant for second line, and then use these agents if they've had inadequate response to get salvage chemotherapy. I think what many of us are very impressed by is the PD-1 data prior to autograft definitely seems to improve CMR rates and overall survival and progression-free survival rates. And therefore, in the UK, some of us are using mechanisms to get patients to that third-line PD-1 inhibitor. So that's maybe using low chemotherapy, but not intensive chemotherapy, and then leading on to being able to use PD-1 inhibitors. So I think that's the favoured option as PD-1, either as monotherapy or in combination with chemotherapy such as GVD. But I think the data does look very good with PD-1, but if they're not available, then BV is an appropriate alternative in combination with chemotherapy. And I think what's really come out of data is the retreatment of patients. So definitely patients do remain responsive to treatments that they've had previously, particularly if they have longer remission periods. So I think it should definitely as well, I think if we are using targeted therapies up front, they tend to be used for fixed duration, and therefore we should look at re-challenging these patients with the targeted therapies.
As novel therapies reshape the relapse setting, the role of autologous stem cell transplantation is also being reconsidered. Dr. Burton reviews emerging evidence suggesting that selected low-risk patients may achieve durable outcomes without consolidated transplant, and highlights the need for improved risk stratification.
Transplantation, as you say, has been the standard second-line therapy for relapsed Hodgkin's lymphoma, but I think it is changing. We know that there is obviously acute toxicity with transplantation, but also longer term toxicity in terms of late infections, cardiovascular risk. So I think we are trying to identify patients where maybe a transplant isn't necessary. It's interesting data about using pembrolizumab maintenance as opposed to stem cell transplant, paper by Alison Moscovitz, that looked at using pembro maintenance after up to 4 cycles of pembro GVD. And interestingly, it did show a good 2-year PFS benefit of 60%. So there were patients that did relapse both on treatment and soon after stopping pembro maintenance. But I think there are patients that potentially could avoid autograft with this mechanism. I think there's other data also using brentuximab, for example, in combination with ESHAP chemotherapy, looking for better CMR rates, and then again using BV consolidation as opposed to an autograft. And the data from there is quite intriguing that maybe that is an option for some patients. There's also other options looking at BV-Nivo, very good PFS rates using that combination for those patients who have an autograft. But additionally, adding in ipilimumab to BV-Nivo does seem to result in some very good PFS rates for a certain patients avoiding autograft. So again, I think that's really encouraging data. I think it's been very much established in the pediatric setting rather than the adult setting. The UNET group have looked at this and defining low-risk patients, so those being patients that have had prolonged time to relapse or have had a very good response to the first line of relapse treatment with at least 50% reduction in tumour volume, and defining them as low risk, and then the high risk patients being those with progressive disease or that have had an inadequate response to relapse treatment. And if you look at comparing those groups, giving either for the low risk group just chemotherapy and radiotherapy or a beam autograft, actually the outcomes look very similar, really suggesting that you could restrict autograft to those patients with primary progressive disease or inadequate response to relapse treatment. And similarly, there's the Checkmate 744 trial, which looked at using BV-Nivo for low-risk patients who had CMR, continue with BV-Nivo, patients who has less than a CR, then had bendamustine, and again, avoiding transplant in these patients with very good PFS and overall survival rates. So I think there are patients that we can avoid transplantation. This has been sort of extrapolated into the adult setting, a paper by Paul Brockelman, who looked at it exactly this, looking at early stage Hodgkin's consolidation there, then either with chemotherapy or a transplant, and actually showed equivalent overall survival and PFS rates. So I think this is a direction of travel that we'd like to go in. I think we probably need clinical trials to actually establish which patients. I think we do need to be better at risk stratifying patients. So I've very much talked about dividing patients into low and high risk based on their response. But I think we do have better mechanisms of doing that. We have PET imaging, but probably ctDNA we could use to identify low-risk patients that have responded very well to treatment, and where a maintenance type approach may be better rather than autograft.
Overall, the Hodgkin lymphoma treatment landscape continues to evolve rapidly. Highly effective frontline options are creating new questions around regimen selection and treatment intensity, while emerging biomarker strategies may enable more personalised approaches to care. At the same time, novel therapies are reshaping treatment sequencing after relapse and prompting renewed debate around the role of autologous transplantation. As these strategies continue to develop, the challenge will be to maintain high cure rates while reducing treatment burden and tailoring therapy more precisely to individual patients. Thank you for listening to this VJHemOnc podcast. To explore more expert insights and interviews in lymphoma, head over to VJHemOnc.com. Be sure to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple Podcasts or Podbean. Until next time.